So I'm gonna talk about this new technology of virtual reality and want to present some data we did during the last year. So I changed the title a little bit. It's about application of virtual reality, a very new technique, to gastroenterology on how to train people and teach people. So I divided my topic in my talk in 3 topics. So first is application of virtual reality in real-time endoscopy, like performing endoscopy using these techniques, then using this hardware but with a regular 2D monitor, and using virtual reality to inspire young medical students to become a gastroenterologist. So this is how it looks like, virtual reality from outside. So it's somehow not very impressive. So you have this ski mask-like head-mounted display on, and you have those controllers with who you control this environment. But when you look inside, so this is a promotion video from the company, you can really do like the whole environment can be just a second. The whole environment can be computer generated. So we were thinking about using this technology in gastroenterology and in endoscopy. So this is how everything started. It was a project last year where we were thinking about how we perform endoscopy. So usually the camera of the endoscope just looks forward. So you have a hard time detecting flat lesions that are on the side of the folds. So we were developing, using our 3D printer, one of these caps that we put on the tip of the endoscope, and you have those 2 of those small cameras, 1.2 millimeters in the diameter, which also look at the side of the bowel wall. So you can visualize also flat lesions that are not in front of the camera but sideways. But the problem with this device is that you have to keep track of all these 3 monitors simultaneously. So we were thinking about how to improve this new method, and so this is where virtual reality came into place. So what I did, I programmed a little program where all of these 3 monitors got fused and simultaneously presented to the endoscoper, in this case Benjamin Walter, one of my colleagues, like very big screens. So this is how we started using this new technology. And then we went on and thought about what problems we might tackle with this new technique. So one of the problems is when you perform an endoscopy and you want to see something more clear on the screen. You push the endoscope, but usually the image doesn't really get bigger because you have a fold in your endoscope. So this forward pushment of the endoscope doesn't necessarily translate into forward movement of the endoscopic tip. So what people usually tend to do is they bend forward. But this forward bending has no effect at all on the endoscopic screen or like on the endoscopic image. So we built this setup where we grabbed the image and we processed it in a PowerBook and gave the image back to the examiner. So this is how it looks like. Oh, we also tracked the endoscope. So this is how it looks like. So Benjamin has this head-mounted display on, and when he moves forward, the image gets bigger. So let me present you this short video how it works. So he was using this model. So this is Benjamin, and this is what he sees. So when he wants to see it more clearer, he just moves his body a little bit forward, and you can increase the screen size. We also because you can't see anything outside, we have a live footage of the endoscope on the lower left, as you can see here. So if you want to introduce something inside the working channel, he can clearly see it, introduce the forceps inside the working channel, and perform the biopsy. This is a more complicated biopsy because he's pretty far away from this polyp. So again, this zooming comes into place. So when he wants to perform the biopsy, he just needs to lean forward, and the image size gets bigger so he can perform long-distance biopsy. So this is just a short example of what this new technique might help us to do. A spin-off project of this is, I was thinking nobody in the near future would put a helmet on to perform endoscopy. So we are thinking about why not using this technique on a regular 2D monitor. So what we did is we tracked the head of the endoscoper. So basically it's the same concept. When you bend forward, the image gets bigger. So this is, I'm performing a gastroscopy and I see something on the screen and I just move my head forward and the screen gets bigger. So this is stepless and it works pretty fine. This is an example where I'm looking at an anastomosis. It's a still image. I just move my head and I can clearly visualize the mucosal layer on a higher magnification. Another example is by Benjamin here. He's performing a colonoscopy, and on the way back, he just moved his head forward to visualize the mucosal layer. And it works, like, as you can see, in real-time endoscopy. This is another example where we were looking at colitis, so it's a minimal colitis, and the endoscope already has features like near focus, and the endoscope has already built-in features like digital zoom here of up to 1.5 times the normal image. And when we use our digital zoom and also increase the structure, you can clearly see that how nicely you can look at the small vessels and describe patterns of those vessels of the colon mucosa. It's like under the microscope. So these were the two first projects. Then we were thinking of what we don't, usually the surgeons have, when they do laparoscopy, two cameras in front. So they have stereoscopic view. But we don't have only one camera, and there's actually, except of Olympus, only one. They published a study right now with two cameras in front of a gastroscope. Usually there are no two cameras built in our endoscopes. So we are thinking about how to generate 3D pictures just using one camera. And this might help to better classify polyps in the Paris classification. Like when you have a Paris 2A plus C polyp here, sometimes it's difficult to describe. So what we did is we were using light intensity of the image to generate a 3D image of the mucosa. So the brighter the colors, the higher the texture. So this is a polyp here, and you can see this is real time also. You just press a button and you can generate a 3D surface of the mucosa. This is one step further to perhaps once measure things, because I think it's very important in endoscopy so that we are able to measure things inside the colon or the stomach. So 3D reconstruction is one step in this direction. The next, because I also teach students in university, and I think it's very important so that young students like gastroenterology and they like to become a gastroenterologist, we're thinking about using VR in our regular teaching, so in our gastroenterology classes. And because when the first impression of VR is so impressive, I ask myself if a VR lesson is capable of teaching the same amount of knowledge, but in a shorter time in comparison to a regular seminar. So what we first did in this project is we developed a program like PowerPoint to generate VR lessons. So what we did is you have all kinds of objects like a patient and a bed, and you want to animate them. So we developed this animation tool where all those objects are registered here, so you can see everything that is in this virtual reality world, and you can decide at what time point they appear. So the bed appears first, and then the patient appears, and you can also attach audio files to each object. So if a patient appears, the teacher can introduce the patient or just tell something about the case. We also have other features, and let me show you how this works. So you have, this is the virtual reality class, and you can put inside those 3D objects, and you can also allow the user to decide when to go on with the lesson. So this arrow gets highlighted, so you just push next lesson, and then another, I'm sorry, I had this only in German, another detail of the presentation appears. What you can also implement are images. So this study was especially about dysmotility disorders, so esophageal dysmotility. So you can put in images like manometry images. You can also put in radiological studies that patient had. So like this barium swallow, where you can admire how the barium like passes the esophagus in this patient. But you can also implement endoscopic videos like this one here to present the students like how simultaneous contractions looks like, and so all of those images and sound can be implemented. We had a quiz, so there are different types of quizzes that you can implement, like he has 10 different swallow studies, and he has to decide which type of disease this patient has. This is one example, but you can also have more hands-on quizzes. For example, this one here, you have different columns, and you have a buzzer, and on the right column, a symptom appears, or an image, or a 3D object, and you can just grab this object and put it on the column, which you think is the right one, and then you press the button, and it tells you if you answered the question correctly. So we performed a study in January this year, and the plan was to take 40 students and randomize them in 50 minutes virtual reality teaching, or 200 minutes of very intensive seminar with a lot of images and group work, and then perform an exam. And the primary endpoint was defined in this prospective study, that the VR group and the seminar group perform maximum 20% different. We also have a lot of secondary endpoints. So 45 students accepted our invitations, and they were randomized to the seminar and VR group. Some patients didn't attend all lessons because they were all voluntary there. So we analyzed 21 students in the VR teaching group and 19 students in the seminar group. And baseline characteristics were pretty much the same. So we had fifth semester. They were all about 22 years old, and the male-female ratio was pretty much similar. Interestingly, very few of them had contact to virtual reality in the previous time. Exam scores were 13.8 points in the VR group and 15.3 points in the seminar group, and this difference is only 9.8, so it's below 20%, and this was significant. So it was non-inferior by our definition. We also had a lot of secondary endpoints like self-efficacy. For example, I feel confident that I can understand the basic concepts or the of anatomy of the esophagus or physiology of the esophagus, or that I can refer a patient with dysphagia for further workup. And so those items, blue is before the intervention and orange is after the interventions, they were all significant. So people really improved after this virtual reality lecture. And we also had usability scales, like how easy was the program to use, and we had a score of 75 out of 100, which is also above average. Basically what But I think it's interesting because we really want young students to become gastroenterologists, and so they thought that this way of teaching them, like virtual reality, they agreed that they would like to try more of these virtual reality applications, and that they want to see more of these offers in medical teaching. So in summary, I hope I could convince you that there is a future for the interaction between the examiner, like the endoscopist, and those 2D screens, perhaps by using virtual reality, and that virtual reality has the potential for supplementing today's teaching. I want to thank Niklas Mehlhase. He's studying informatics, and he helped me a lot with all this programming stuff. The Dean's office, we have our own VR lab, so 3 of those head-mounted displays are for the students there. They can use them. And Alexander Meining, I'm in his research group. He supported me a lot with all those projects. And Thomas Seuferlein, he's the head of the department.